Good morning students, hope you all are fine. Today we are going to discuss about the Kawasaki disease. So Kawasaki disease, it is an idiopathic multisystem disease characterized by vasculitis of the small and medium blood vessels including coronary arteries. So here there is an inflammation of the vascular bodies or vascular vessels. So it is a vasculitis of small and medium blood vessels including the coronary arteries. It is a self-limited vasculitis of unknown etiology. Actually, the etiology is not known. And it is self-limited. It is that predominantly affects the children younger than 5 years. Kawasaki diseases mainly affect the children younger than 5 years. It is now the most common cause of acquired heart diseases in children. So later on, the children who develop the Kawasaki disease may develop the acquired cardiac diseases also. And it was first explained by Dr. Tomisaku Kawasaki. Epidemiology is 80% of the cases in children is less than 4 years, and the males are more prominent. That is, there is a double chance of occurrence of disease in the females than in males. That is, incidence is 2:1. Then the positive family history in 1%, but 13% risk of occurrence in twins. Then in hospital mortality, it will be almost 0.17%. Then an annual incidence of 4 to 15 per 1 lakh children under 5 years of age. And there is a seasonal variation, that means more cases can be seen in winter and spring, but occurs throughout the year, but most of the cases can be seen in winter and spring season. Then Kawasaki disease, the phases of the Kawasaki diseases can be classified into 3 phases, that is acute febrile phase, subacute phase and convalescent phase. So that is acute febrile phase means it will last for 1 to 2 weeks. Then subacute phase means it will last for 2 to 8 weeks from the onset, and the convalescent phase means it will prevail for months to years later. Okay, so in the first phase, that is acute febrile phase, 1 to 2 weeks from the onset. It is characterized by febrile features, that is a child will have high fever, the child will be irritable, there is a toxic appearance, then oral changes will be there, rashes, edema and erythema of the feet. Then in subacute phase, that is 2 to 8 weeks after the onset, there will be desquamation. Desquamation means peeling of the skin, especially the extremities. Then it may have persistent arthritis or arthralgias, inflammation of the joints or pains in the joints. Then gradual improvement even without treatment. Then convalescent stage, that means it will last for months to years later, or it will reoccur after months to years. Then acute febrile phase, stage 1, we can see it in detail. That is, it is the first 10 days of illness. Acute febrile phase is known as the first 10 days of illness. The child appears severely ill and irritable. The following 6 diagnostic criteria of Kawasaki disease occurring during the acute phase. We can see the 6 criteria or 6 diagnostic manifestations during this stage. That is, high spiking fever. I have already told you that in febrile fever there will be high fever, that is up to 105.8 degree Fahrenheit, and it lasts for 5 days or more. Then there will be bilateral conjunctival infection of the conjunctiva of eye. Then oropharyngeal erythema, then strawberry tongue. It is one of the classical manifestation of Kawasaki disease. That is red and dry lips. Then indurative edema of the hands and feet. Then erythema of palms and soles. Then generalized edema. Then perilingual desquamation. Then erythematous rashes. Then cervical lymphadenopathy, at least one limb not greater than 1.5 centimeter. So these are the 6 diagnostic criteria. That is high spiking fever, bilateral conjunctival infection, oropharyngeal erythema, strawberry tongue, then indurative edema of hands and feet, erythematous rashes, then cervical lymphadenopathy. The next is carditis. There is pericarditis, myocarditis, cardiomegaly. There is enlargement of the entire heart failure, and the pleural effusion may appear during the acute phase. Then other associated findings during this phase include meningitis, then sterile pyuria, and then there's pus in urine, then arthritis, then GI symptoms like vomiting and diarrhea, and perineal rashes. The next is subacute phase, stage 2, that is 11 to 25 days after onset of illness. There will be acute symptoms of stage 1 subside. After the subsiding of the symptoms in stage 1, that is, the temperature becomes normal. After that, there will be subacute phase. The child remains irritable and anorectic. Anorectic means there will be some manifestations of that is loss of appetite. Then dry crackled lips with fissures. Then desquamation of the toes and fingers. That means there will be peeling of the skin in the toes and fingers. Then significant cardiovascular changes including coronary aneurysm. Aneurysm means dilatation of the vessels. Or ballooning of the blood vessels, especially the great blood vessels, and thrombosis and myocardial infarction and heart failure occur in this phase. Then approximately 20% of the patients develop coronary aneurysm. Then there will be thrombocytosis. It will peak at about 2 weeks during this phase. Thrombocytosis means there will be increased level of platelets in the blood. The next is convalescent phase or stage 3. That is here the ESR and platelet count become after, and that means in the second stage the ESR and platelet count will be high. So by reaching the convalescent phase, the ESR and platelet count will become normal. The child appears well. There will be transverse grooves of fingers and toenails. We can see groove. That means we can see some depressions on the toenails and fingers. In coronary thrombosis, aneurysm may occur. Then what about the fever in Kawasaki disease? What is the characteristic of the fever? The fever is characteristically very high, that is normally above 101 degree Fahrenheit, unremitting and unresponsive to antibiotics. That is the main feature. It is unresponsive to antibiotics. The duration of fever without treatment is generally 1 to 2 weeks but may persist for 3 to 4 weeks. Then effervescence within 1 to 2 days of treatment with defervescence with 1 to 2 days of treatment with intravenous immunoglobulin. That is defervescence means the fever will reduce for 1 to 2 days, and again it will come back even if we are treating it with IV immunoglobulin. Then what about the conjunctivitis? The conjunctivitis, it begins shortly after the fever. It resolves promptly and may have disappeared by presentation, and there will be non-purulent conjunctival infection. There will not be any pus discharge. Then bulbar conjunctivitis with limbic sparing. Limbic sparing means here there will be a part of the sclera around the that means around the iris remains white. That is limbic sparing, and anterior uveitis may occur up to 80%. Then oropharyngeal changes, I have already told one of the classical signs is strawberry tongue. Then erythema, dryness, swelling and peeling of the lips. That is known as lipstick sign. That means we may feel that the child have applied lipstick on the lips. Then lips may bleed, erythema of oropharyngeal mucosa. Then no coplic spot or oral ulceration or exudates in Kawasaki disease. Then changes in the extremities, I have already told there will be desquamation. Then edema of the hands and feet, especially in infants, and peeling of fingers and toes or desquamation. Then peeling of hands and feet in subacute phase. Then Bue's line in nails. Occasionally nail is lost. Sometimes the nail is lost or there will be grooves. That is known as Bue's lines. Then polymorphous rashes generally occurs within onset of fever and fades within a week. Then morbilliform rashes. Morbilliform rashes means there will be rashes, that is there will be they are flat rashes without any eruption. That is morbilliform rashes on the flexor creases. Flexor creases means it is a creases of the finger. This one. There are some natural creases on our fingers and legs from the prenatal period itself. That is flexor creases. So on the flexor creases there will be rashes. Then erythema and desquamation of the inguinal or perineal area. That is desquamation of hands and feet. Then presence of petechiae or purpura. Then vesicles or bullae, crusting, pruritus. Search for an alternative diagnosis. In some cases we may mistaken that there may be some other diagnosis, especially any skin condition. Then lymphadenopathy, 50 to 80% of cases of lymphadenopathy. The lymphadenopathy will be greater than 1.5 cm, usually more obvious. And it may be unilateral single node lymphadenopathy, and it may be erythematous but non-fluctuant, and there will be no pus. Then other signs and symptoms are respiratory. In respiratory there will be rhinorrhea, cough, pulmonary infiltration. In GI there will be diarrhea, vomiting, abdominal pain, high drops of the gallbladder, and jaundice. High drops means the swelling of the tissues due to fluid accumulation. Swelling of the tissues due to fluid accumulation. Then neurologic, there will be irritability, aseptic meningitis, facial palsy, and hearing loss. Then in musculoskeletal, there will be myositis, that is inflammation of the muscles, arthralgia and arthritis. Then in Kawasaki disease, there is a diagnostic criteria called AHA diagnostic criteria, that is American there is a diagnostic criteria which is proposed by American Heart Association, that is there will be fever greater than or equal to 5 days duration plus 4 or 5 criteria. That means I am going to tell some criteria along with fever. These criteria, if any of these criteria is present, the child is having Kawasaki disease. The first criteria is oropharyngeal changes, especially the strawberry tongue. Then second is changes in the peripheral extremities. Now in 90% of the case, there will be swelling of the peripheral extremities as well as desquamation. Then bilateral or non-purulent conjunctival infection. Then polymorphous rashes or cervical lymphadenopathy. So in most of the cases, there will be oropharyngeal changes, then changes in the peripheral extremities, then non-purulent conjunctival infection as well as polymorphous rashes. In some cases, only cervical lymphadenopathy is present. So along with high fever, if any of these 4 criteria is present, then it is known as Kawasaki disease. Then cardiovascular manifestation of acute Kawasaki disease are, there will be ECG changes like arrhythmia, prolonged PR or QT intervals, then low voltage, then ST wave changes. Then in chest X-ray, there will be cardiomegaly. Then in coronary artery, there will be changes like it vary in severity from echogenicity due to thickening and edema or asymptomatic coronary artery, ectasia to giant aneurysm. Ectasia means dilatation, that is dilatation to it may become giant aneurysm. Then it may lead to myocardial infarction, sudden death or ischemic heart diseases. Then in coronary aneurysm, there will be patient most likely to develop aneurysm younger than 6 months, older than 8 years. That means between this age, then males are more predominant. Then fevers persist for greater than 14 days. And persistently elevated ESR. Then thrombocytosis. Then patients who manifest signs and symptoms of cardiac involvement. Then another type of Kawasaki disease is atypical or incomplete Kawasaki disease. It is present with less than 4 or 5 diagnostic criteria. Compatible laboratory findings will be there. Then still develop coronary artery aneurysm. So coronary artery aneurysm is one of the important manifestation of Kawasaki disease, and no other explanation for the illness. Then more common in children less than 1 year of age. Then in lab investigation, there will be increased total leukocyte count, decreased hemoglobin. Then in platelet, it will be normal in the first week, but it will increase. The platelet, that means there will be thrombocytosis in the second and third week. Then ESR will be elevated. Then C-reactive protein will be elevated. SGOT, SGPT are elevated. Then pus cells are more in urine. Then CSF pleocytosis. Pleocytosis means there will be presence of lymphocytes in the CSF. Actually, the CSF does not contain any lymphocytes. If there is CSF pleocytosis, then it is a positive manifestation of Kawasaki disease. So in Kawasaki disease, we can see almost all the blood components are increased except hemoglobin. Then echocardiography, we can see we can diagnose this disease through echocardiography, and we can repeat the echocardiography in every 2 to 3 weeks. And if results are normal, a repeat study should be performed 6 to 8 weeks after the onset of illness. Then poor prognostic markers are, first is if the child is having young age, there is a less chance of prognosis. If the child is male, then persistent fever, poor response to intravenous immunoglobulin. If the child is not responding or poor response to intravenous immunoglobulin, the prognosis is poor. Then laboratory anomalies like neutrophilia, thrombocytopenia, then transaminitis. Transaminitis means there will be increased amount of enzyme called transaminase. Then hyponatremia, hypoalbuminemia, elevated CRP level. Then Asian and Pacific Islander race and Hispanic ethnicity. Then management category, first is pharmacological therapy, that is intravenous immunoglobulin 2 gram per kg as one-time dose. Then aspirin, high dose, that is 80 to 100 mg per kg per day until febrile for 48 hours, or decrease in acute phase reactants. Then decrease to low dose, that is 3 to 5 mg per kg per day, or for 6 to 8 weeks, or until platelet level normalized. So we are giving aspirin in high dose for 48 hours, then decrease the dose for 6 to 8 weeks until the platelet level normalized. And physical activity, it decrease the physical activity for 4 to 6 weeks, and follow up and diagnostic testing is much important. Then we can do invasive testing also. Then treatment in the acute phase, we are giving IV immunoglobulin 2 gram per kg over 10 to 12 hours, aspirin 80 to 100 mg, that is high dose, and divided dose every 6th hourly, orally until the patient is afebrile for at least 48 hours. In convalescent stage, we are decreasing the aspirin dose to 3 to 5 mg per kg per day once daily orally until 6 to 8 weeks after illness onset. If normal coronary findings are there, then throughout the course. Then long-term therapy for a client with coronary artery aneurysm. Okay, long-term therapy. If the child is having coronary artery aneurysm, we will give long-term treatment. That is aspirin 3 to 5 mg per kg once daily orally. Then clopidogrel 1 mg per kg per day, maximum 75 mg per day. Then most experts add warfarin or low molecular weight heparin for these patients at particularly high risk of thrombosis. Then acute coronary, if the child is having acute coronary thrombosis, then prompt fibrinolytic therapy with tissue plasminogen activator or other thrombolytic agents under supervision of a pediatric cardiologist. Then we are checking the Harada score. Harada score is used to determine whether the intravenous immunoglobulin treatment will be used. So intravenous immunoglobulin is given to children who fulfill 4 of the following criteria assessed within 9 days of the onset of illness. That means intravenous immunoglobulin should be continued to who fulfill the 4 of the following criteria. That means if I am going to tell 4 of the following criteria. If any 4 of the following criteria is present within 9 days of onset of illness, we have to give IVIG or IV immunoglobulin. Okay. So the first criteria, that means that is Harada score. In Harada score, we are assessing 5 criteria. So if any of the 4 criteria from the 5 steps is present, then we are giving immunoglobulin through IV. So first is white blood cell count greater than 12,000 per millimeter cube. Then platelet count less than 350,000 per millimeter cube. Then C reactive protein more than 3. Then hematocrit less than 35%. Then albumin 3.5 gram per dl. Then age less than or equal to 12 months and male sex. Okay, I have already told 7 criteria in Harada score. Okay, if any of the 4 criteria is positive, then we will give IV immunoglobulin. That is, the 7 criteria are white blood cell count greater than 12,000 per millimeter cube, platelet count less than 350,000 per millimeter cube, C reactive protein 3 plus, hematocrit less than 35%, albumin less than 3.5 gram per dl, age less than or equal to 12 months and male sex. If any of these criteria are present, then we will go for IV immunoglobulin therapy. The nursing assessment focus history on gathering data that support the diagnosis of Kawasaki disease such as fever and skin manifestations, and perform physical examination concentrating on the cardiovascular system. Then nursing diagnosis are acute pain related to conjunctival inflammation and arthritis, decreased cardiac output related to pancreatitis, vasculitis, aneurysm, heart failure or myocardial infarction. Then impaired oral mucous membrane related to disease process. Then risk for impaired skin integrity related to edema, dehydration, desquamation and bed rest. Then deficient fluid volume related to hypothermia, anorexia and oral ulcer. Then fear of parents and child related to severity of illness and hospitalization. Then in reducing discomfort, the nurses should offer pain medications on the scheduled basis rather than as needed during acute phase as per the physician's order. Then perform comfort measures related to the eyes, that is conjunctivitis can cause photosensitivity. So darken the room and offer sunglasses to the child if the child is having conjunctivitis. Then apply cool compresses. Then discourage rubbing of eyes. Then instill artificial teardrops to soothe the conjunctiva. Then perform comfort measures related to joint pain and tender limb knots. Use passive range of motion exercises every 4th hourly while the child is awake because movement may be restricted. Then allow and encourage the child to move about freely under supervision, provide soft toys and quiet play, and encourage use of hands and fingers, monitor pain level and child's response to analgesics, and provide quiet, peaceful environment with diversional activities such as listening to music. Then maintain cardiac output, institute continual cardiac monitoring and assessment for complication, take vital signs and BP as directed and as indicated by the condition, report abnormalities. Then make sure cardiac monitor is functioning properly, observe for and report any arrhythmia. Then assess the child for signs of myocarditis, that is tachycardia, gallop rhythm, chest pain. Then monitor the child for heart failure. That is, heart failure, the manifestations are dyspnea, nasal flaring, grunting, retraction, cyanosis, orthopnea, crackles, moist respiration, distended neck veins, or edema. And closely monitor intake output chart and administer oral and IV fluids as ordered. Then if administering IV immunoglobulin, then give premedication as directed and monitor closely for adverse effects. Monitor BP and heart rate at the start of the infusion after 15 minutes, after 30 minutes, and then hourly until the infusion is complete. Then slow the infusion and contact the healthcare provider to evaluate the child for any drop in BP. Then keep medications to treat anaphylaxis like epinephrine, Benadryl, and other emergency medications readily available. Then prepare the child for cardiac surgery or thrombolytic therapy as indicated. Then preserve the oral mucous membrane because there is a oral thrush or formation of strawberry tongue. So in that case, offer and encourage frequent cool liquids, that is ice chips and ice pops. Then progress to soft bland foods. Then give mouth care every 1 to 4 hours with special mouth swabs. Then use